Now, it may not be possible for us to be culturally competent for all people, but our goal should always be to be culturally sensitive in all situations. You're listening to Pediapain Focus, episode number 42, and we're talking about no difficult patients, no difficult families, nada, zilch, ever. Now, wouldn't that be nice? To find out, stay tuned, my dear.
Pediapain Focus.
You're listening to Pediapain Focus, brought to you by Proactive Pain Solutions. Pediapain Focus highlights pediatric pain information and provides tools and resources for all healthcare professionals taking care of children dealing with pain. Here's your host, Dr. Anjana Kundu.
Hey there, it's your host, Dr. Anjana Kundu here. Welcome to Pediapain Focus. Now, let me ask you, have you ever had a patient or a family you are taking care of and where you just wanted to turn right around and leave? Or maybe you wish that they would leave? Or perhaps you hoped that someone else could see them instead of you? Or maybe you're like one of my colleagues who used to say when they were faced with a difficult case, I'm going to go check if I've been fired yet. You don't need to do that. But I'm pretty sure you're either nodding your head or maybe you're saying yes out loud. Chances are, if you practice medicine in any capacity, you have experienced that firsthand, my dear. At least at bare minimum, you know someone who has encountered such a situation. In the medical community, these end up getting labeled as difficult patients or families. And over the years, many articles have been written about taking care of quote-unquote difficult patients. In 1978, James Groves, a psychiatrist from Mass General Hospital, even wrote a paper that was entitled, in quotes, Taking Care of the Hateful Patient, unquote. He went on to categorize these patients into 4 types of patients. And if you're talking about pediatric pain patients, I suppose this would also apply to the caregivers or the parents. These are dependent clingers, entitled demanders, manipulative help rejectors, and self-destructive deniers. And he goes on to say that even the most seasoned physicians dread taking care of these patients and families. And then this topic was revisited and updated in 2006 by Strauss et al. And over the years, there have been some debate over the psychoanalytical theory and the terminology or the labeling that Dr. Groves had used. However, most of the articles still continue to focus their writings or their opinions on patients and or families being difficult. Now, I would say this is a little unfair to just pin this on the patients and families and give them this label of difficult or hateful. I beg to differ from this labeling. I would even go out on a limb and say that I don't believe that there are any difficult patients or difficult families. Now, having been involved in medicine for over 30 years now, of which nearly 2 decades, I've been taking care of children with pain issues, complex pain issues, and their families. Now, whether it was acute, chronic, complex care, I've done it all. And I would say that during these 2 decades, or really in these 30 years of my involvement in medicine, I've become even more convinced that there are no difficult patients. That's right. I said it. There are no difficult patients, just difficult situations. Now, I know what you might be thinking. You're probably thinking, say what? You must be nuts. How can you say that? The quote-unquote difficult patient or family is the bane of every clinician's existence. Or you might be saying, hey, wait a minute, didn't you just do an episode about the differences in opinions and the malalignment between patients? That too just a week ago? Well, yes, I did, and I will include the link to that as well. And no, my dear, I'm neither nuts, especially not at least when I'm talking about pediatric pain management, but if you ask the home front, you might get a little bit of support on that claim. Okay, jokes aside. If anything, My last week's episode actually supports my claims of today's episode, and I'm sure you will also see this even more clearly as we proceed further and as you listen to this episode. And if you don't agree with me on my claims of no difficult patients and perhaps you're about to turn away, I'm going to ask you to come back, stay with me, hear this episode, if only to prove me wrong. But I would say most importantly, you should stay because at the end of this episode, I am confident that you will leave here with valuable insights for turning those seemingly dreadful or what Dr. Groves referred to as the hateful patients, those visits. You'll be able to turn those visits into positive, productive, and gratifying encounters of your own. And at bare minimum, you will be equipped with a much more productive and proactive approach to these types of patients and family encounters, leaving you a more satisfied and confident clinician in your work, regardless of the situation. So you see, my friend, this one is one of those must-listen episodes for anyone who takes care of any patients, but particularly if you take care of patients with pain issues, and especially if you are likely to disagree with me as I refute the difficult patient or difficult family labeling. Now, don't get me wrong. This is not to say that all is hunky-dory, peachy, and smooth sailing. I'm not asking you to simply adopt a Pollyanna attitude or deny the existence of these patients and family encounters that make us upset. They make us want to bang our heads against the wall. The encounters which take every ounce of energy in our body to keep our cool and patience, and perhaps at times even make us question the very decision of going into medicine. I know. Sometimes those situations have occurred to most of us if you practice this long enough. That's not what I'm saying. Those situations will occur. In fact, there are about 15% of all patient encounters that have been classified as, in quotes, challenging. And from time to time, all clinicians will encounter patients or caregivers whose behaviors may invoke negative emotions. Patients and families have certain expectations. They have some preset ideas, desires, or personalities or reactions, including those of, say, defensiveness, anger, fear, demandingness, hysteria, or even secondary gain. And those could make for a very unpleasant encounter, if not identified or addressed appropriately. But simultaneously, on the other hand, the countertransference of negative feelings from a healthcare professional's perspective, whether it's done unconsciously or subconsciously, it is inevitable, at least with some of these patients and families. And what happens with such feelings is that they're likely to intrude on the health of the patient-clinician relationship. But what we need to really remember is that not all difficult patient visits can or should be pinned just on the patient. As I just said, it could be coming from the clinician too. Heck, it could be unrelated to either one of those, and we'll talk about those in just a moment. But personally, I don't think or believe that most people are difficult. Sure, different things, factors, etc. will contribute to a difficult encounter, meaning there can be various reasons or things that push our buttons on both sides, whether you are a healthcare professional or a patient or their caregiver. Now, again, I'm not saying that you need to be in denial of those gut-churning, dread-evoking situations. But remember, these are situations and encounters and interactions, and they are not just the patient or caregiver's personality or their characteristics, right? So why just label them as difficult? Now, we all know when something in healthcare does not go as planned or it departs significantly from what we had anticipated, we do a root cause analysis of what might have contributed to the unintended outcome. And it's only rare, if at all, that we will simply assign blame to a person or label them incompetent or failure or any such thing upon a thorough root cause analysis. It's usually a multitude of things. And this is no different here either. So why then, when things don't go well with a patient encounter, should we simply blame the patient or the family or the caregiver for it? And why should we label them as difficult? Now, I encourage you to take a closer look at all these difficult encounters and see what is at the root of these. Instead of just labeling our patients and families as difficult, make sure that you have taken the time to analyze it. Because the truth is, as long as there will be human interactions, there will likely be points of conflict, and this is never truer than when it comes to people's health, especially when it concerns a child's care, and even more especially when it comes to your child's pain and the suffering that it unleashes on your child and your lives. Pain is one of the most difficult and disempowering conditions, and it often evokes many of those negative emotions and behaviors amongst patients and caregivers, like we were talking about, the defensiveness, the anger, even the mistrust and hopelessness. Now, if you might be thinking, well, great, Anjana, even if we don't call it a difficult patient or parent, and maybe we instead say it's a difficult situation or difficult encounter, does that really change anything? Does it change the fact that I am still having to address these same challenging issues, no matter how you want to repackage it or relabel it? Well, to you, I would say it does. It does make a difference. It makes a big difference how we approach a situation. It makes a difference to the patients and families, and it makes a difference to you as a healthcare professional. When it is pinned on patients or families, it creates a us versus them dynamic. And even though that may never be your intention, nor should it ever be, right? But because our destination, the destination that your patient and family desires, and the destination that you desire for them, and our goals, they're all the same. It's the well-being of that patient with best outcomes. But when you're coming at a problem as opponents, it's really hard to reach that same goal and that same destination. Another thing is, if you view the patient or family as difficult, that is a personal feeling and judgment that you are harboring for that patient and family. The negative feelings evoke more negative emotions, and your objectivity is likely to get clouded. Any information presented by them, meaning by the patient and families, is automatically going to be filtered through a tinted glass of your own feelings and emotions. And it's likely to hold less credibility, likely to hold more skepticism from you, and it may even evoke even more judgments or negative feelings and reactions from you, thereby impacting your ability to provide the best care for that patient objectively. Not only that, negative feelings and emotions have a way of spreading across to those that are around us, and it becomes a self-propagating prophecy. Research shows that there is a mirror effect of the dominant emotion and attitude, and it shows up in the CNS and the CSF analysis of people in your vicinity, even if they have no direct interaction with you. But obviously, much more so if you are actually having an interaction, as you would with your patients and families. So basically, it's not only affecting how you care for the patient, it also affects you and your patients and families personally, and that too negatively. They too then can become even more defensive. They can withhold any important information, or they may not follow the directions and treatments and plans because then they don't trust you. However, the good news is that this very scientific data can be used to improve the situation on both sides, both for the patients and for the healthcare professionals. So now let's look at how we can address the occurrence of difficult encounters or situations. So basically, we're looking at why do difficult situations and encounters occur? Which means we're going to first look at the contributing factors to that situation. In other words, we are doing a root cause analysis of this situation right here. So I tend to categorize the contributing factors into 3 categories. Number 1, the patient or family or caregiver factors. Number 2, the clinician or the healthcare professional factors. And number 3 are the situational or circumstantial factors. So let's look at them one by one. The patient and family factors. The patient characteristics that may suggest the likelihood of difficult encounters may include, number 1, patients who are angry or frightened about their disease or their diagnosis. Now remember, no one wants to expose their own vulnerabilities or insecurities. Instead, they may present with a defensive attitude, a sense of entitlement, or a pseudo-bravado. They may be coming with clenched fists, furrowed brows, hand-wringing, huffing and puffing, basically an abrasive mannerism, right? You know, these are the kinds of patient that your frontline office staff tells you about even before you get into the room. Or at least you hope they will if they like you. Number 2 are the patients with chronic health issues. These may include the chronic pain patients, complex chronic condition patients, or in other words, patients that we lovingly refer to as the frequent flyers. Such patients may be frightened of their disease, they may not be adequately informed of their condition, and they may feel afraid at the slightest change. Or perhaps they were misinformed about their condition. And here you may think about all the freely available information that's available on the internet, Dr. Google, right? Or maybe from well-meaning friends and families or the other support groups that they may be part of. That unfiltered ocean of information that may have scared your patient or given misconceptions. They may not have the resources to take care of their conditions by themselves. So these may be some dependent patients. They may be dependent because of the resources and or even just their own personal characteristics may not be conducive to taking care of a serious illness. Or perhaps they may be lonely or they may be embarrassed about their condition. Other category is the patients with more severe symptoms. These patients may feel that they're not being listened to, they're not being believed or cared for, and that's why their symptoms continue to be more severe, untreated. And they may feel that the treatments are being withheld from them and may have some mistrust of you as a healthcare professional or the entire healthcare system. Or perhaps they're just fearful what this severe symptomatology may mean for their prognosis. Number 4 are the patients with somatization tendencies. Now, many of these patients may present frequently with histories of multiple vague complaints or exaggerated symptoms, or even often may display the symptoms of comorbid anxiety and depression or other mental health issues. These patients often engage in doctor shopping. So when you see a patient that's coming repeatedly, it may raise certain concerns. It may be perhaps they are just somatizers, but it can also be, remember, for complex chronic pain patients, the average number of clinicians that they will be seen by is between 8 to 15. So for those patients, you also have to be mindful that it perhaps may be simply that they haven't gotten to the right treatment plan yet. Number 5 are patients with mental health diseases or mental health diagnoses. This is a whole different ballgame, and personally, I would recommend that you invoke a psychiatric and mental health professional help early on for those patients. Number 6 are the patients who have secondary gains to come from their condition. So these may present as manipulative patients. They may use guilt, rage, threats, legal action, or suicide, or other impulsive behaviors. And these are all done in an attempt to get what they desire. So it's important to understand what's driving the behaviors. Number 7 are patients who may be defensive. And they may be defensive because of their previous encounters, whether it's healthcare related or even some personal experiences they may have had that put them on guard. And it could just be simply related to their personal circumstances in life. So those were the patient or caregiver related issues. Now let's look at the clinician or healthcare professional factors. A clinician's attitude about the care that they ought to or need to provide, their level of fatigue, stress, and burnout, they can all create circumstances in which clinicians are responsible for creating these difficult situations themselves. The personality trait of a clinician may also play a role, as well as the clinician's personal biases or beliefs. They all contribute to the quality of the encounters. So, what can clinicians look like? A defensive or angry clinician, that may be a result because they are burnt out, they're stressed, they're generally frustrated over the long-term or the short-term concerns. They are more likely to react negatively to all patients, not just the so-called difficult patients or patients that are challenging or the categories that we just discussed above, but even other patients without any of those characteristics, and still may contribute significantly to the difficulty of the encounter. Now, recognizing your own triggers as a clinician, your own issues, personal issues, and knowing what personal baggage that you might be bringing into the exam room is extremely valuable. And not just knowing it, ideally knowing and then shedding them or keeping them separate from this encounter. Number 2 are the fatigued clinicians. This is different than the burnout physicians because when we are overworked, we're sleep deprived, and this may be related to the work situation or maybe other things that are going on in your personal lives or other responsibilities, right? If we are generally busier than we need to be, which of course happens from one time or another, obviously we witnessed this very well during this pandemic. Now then, we tend to have less patience. We tend to experience how fatigue causes clouding of judgment and it reduces the ability to take things objectively. Moreover, the impact of physician fatigue on medical errors and patient safety has been well documented and may also play a role in flavoring the encounter of the clinician-patient interaction. The next category are the clinicians who are under pressure. For example, the productivity pressures from short visits and their performance being judged on the productivity that they have at work. And with the changing healthcare environment and perhaps their overcommitment, whether it's related to work and or their personal lives, this is closely related phenomena to what we all know as too common among high-achieving professionals. And now add to that all the other productivity pressures, then this just leads to an untenable situation, which leads to frustration and feeling jaded, and therefore that all comes out in your patient interactions. Then there are the clinician's personal characteristics or their attitudes. So the dogmatic or the arrogant clinicians play a big role in difficulty of the encounters as well. Now, each one of us has things that we feel strongly about, personal beliefs and values, as well as our beliefs and values about the medical care. Now, this can lead us to overemphasize our own beliefs and emotions in the ways that tends to disempower our patients and families, or it may prevent them from giving us the adequate information about their healthcare, therefore impacting your ability to perform your best and give them what they need. This may even result in a power struggle. In pediatric pain medicine, where our discipline is fraught with myths and misconceptions surrounding the children's pain and its management, the dogmatic and arrogant approach is definitely a big downfall. And a clinician's personality and personal beliefs carry the risk for further perpetuating those misconceptions, as well as the patient and clinician's mistrust, their anger, their defensiveness, or even their hopelessness. In other words, this is a perfect storm for a difficult encounter. Now, the third category we talked about is factors that are not related to two parties involved, so the personnel involved in it. And those are the situational factors. Situational factors are that sometimes difficult encounters have more to do with the circumstances surrounding the encounter than the people involved in it. What would those be? There could be language barriers. In a country like US, where we have a diverse population with many languages, communication may get missed or dropped. So here, a value of good interpreters or even how we use them is going to be really important. So how we handle those language barriers is going to be imperative. Number 2 are the cross-cultural differences. Again, in a diverse country like US, there are many cultures, many values, many belief systems. Now, it may not be possible for us to be culturally competent for all people, but our goal should always be to be culturally sensitive in all situations. Then there is the issue of the diagnostic ambiguity. In conditions like pain especially, where you may not have the exact diagnosis, and many other conditions that we don't know. When there's diagnostic ambiguity, it leaves both the patient as well as the healthcare professionals a little disarmed, and perhaps this may result in a more difficult encounter as well. Then there's the patient's personal situational factors, which could be outside of that may be completely unrelated to what's happening during the visit. It may be something that's occurring at the home. For example, the parents may disagree amongst themselves how to handle the situation, how to even support their child. There may be family discord. There may be discord among siblings. All those situational factors will also play a role in what and how the patient and the family or the caregiver shows up. We talked about the productivity factors and how it impacts the physician's perspective and how they show up during this interaction. So this may have direct and indirect effects on the quality of the encounter. Then people have their personal biases. So it may not even just be related to the particular situation or encounter or circumstance, but they may have implicit or explicit biases that we all carry, whether it is the patient or the family or the caregiver or the healthcare professionals. So our own baggage may also prevent us from assessing the information without a bias, regardless of which party it's coming from. Next thing is the circumstantial triggers. These are things that are completely unrelated. They may be the family, the patient, the caregiver's expectation of what they need to be. Perhaps they culturally are expected to be the stoic person. There may be a high pressure from their job or from family. There may be more demands on them. All those issues that are unrelated may be impacting how they're showing up during this interaction and this visit. So now we've looked at all the different factors that impact the quality of encounters. What do we do with them? To some extent, I've peppered what sort of things you as a clinician need to do. But let me just summarize those and buff them up a little bit more. So understanding the motivation or the behavior and being aware of the situation and of the driving factors can help a clinician to emphasize as well as empathize with the patient, even when your patient may not be as gracious. They may not be presenting as cooperative or gracious or as pleasant as you want them to be. However, remember, you are the expert. You're the professional. There's a slightly higher expectation from you. You are expected to be able to analyze, assess, and manage those as well. And how do you do that? Well, number one, keep the goal in mind. Even when the patient or the caregiver appears to be uncooperative, the goal usually is the same, and that is to find the best possible treatment, the best care for that child or for that patient or for themselves. And from the healthcare professional's perspective, it is to be able to find that with utmost professionalism and empathy. So that's a common goal. And the best strategy is often to be able to steer that encounter away from a power struggle and giving some legitimacy to the patient's feeling of entitlement, but in the context of how that is going to allow us to get to the best possible treatment. I know that sounds a little more complex than it needed to be. Basically, what I'm saying is we need to be able to create a situation where instead of us versus you mentality, that my word holds more than yours, what we need to do is to create an understanding and cooperation and collaboration to be able to address the common need, which is the patient's condition, situation, or their goals or their expectations, right? Therefore, take a collaborative stance with the patient with the common goal of finding and implementing the most effective and lowest risk solution to their desire, their need, and their goal. Empathy and exploration of your patient's concerns is going to be your best option here. We need to have our investigative hats on. We need to be interested and inquisitive in where our patients are coming from, what they may really desire underneath that facade of whatever they may be presenting as. So the keys to managing a difficult or challenging encounter are, number one, recognize whether it's you or the patient or family or both of you that is contributing to this difficulty of the encounter. It's important to be aware of your own emotions, and if it turns out that it's you, then excuse yourself for the moment. Take a deep breath and think to yourself, what am I bringing to the table? And then leave that outside of this interaction. Ground yourself, whether it's in the moment or a more generalized approach to being a more grounded and well clinician. So you must also focus on your overall well-being, because if you are burdened with fatigue and overcommitment or the situation at work or home, and you're always carrying that burden, that will color your ability to provide the best possible care to your patients. Number two is we must attempt to understand the patient's perspective, their fears, their worries, and their expectations. We must try to look through their lens if possible. Remember, anger and hostility are often motivated by fear and a sense of losing control. And as we talked about, nothing is more disempowering and gives you a sense of loss of control than a healthcare ailment, especially pain conditions. And when it comes to your child's pain and suffering, it's even more dramatic. For many people, it's either their best or their worst that presents itself at the time of a health crisis or a illness. Now you have to remember that their feelings are driven by their experiences, and by recognizing and discussing them with them, you can certainly help. Understand their fears or their worries or their expectations, which often could be very reasonable, even if their behaviors don't appear to be very rational. And that might be very helpful in giving you a direction to diffuse the situation. Now, I'm not saying that you can't say no to their irrational behaviors or expectations. As a matter of fact, I'm actually asking you to use your quality as the leader, as the expert, to help them see what really should their direction and their desires and their expectations be. But you must do this with empathy. Now, empathy will be your best weapon. Although I must say, it seems a bit wrong to categorize empathy as a weapon. So let's call it superpower. So empathy is going to be your superpower. Therefore, the number 3 point is be empathic. Let your patients and their families tell their story. Try not to interrupt them or cut them off, but gently steer them towards or redirect them towards what's relevant to their condition at hand and their symptoms and their illness, and how that's likely to get you both to the common and shared goal. Legitimize their concerns to an extent, right? It always has to be to the right extent. Again, step into your power as the physician leader, the clinician leader, and the expert. You don't need to be bullied by the illegitimate demands. However, you can always acknowledge, even if they're illegitimate, acknowledge their feelings, their concerns, and then gently and expertly steer them towards the more productive outlook, or that what I call the therapeutic triangle. Remember, we were referring to it as tactfully directing both your attentions to the common point of the triangle, which is the best healthcare outcomes or treatment plan for your patient. And you must do that by avoiding conflict. Acknowledge the situation, even if it means that sometimes you may have to just say it out loud, something like, I feel like we're getting off on the wrong foot. Let's see if we can make it right, because our destination is the same and we're on the same team. We both want the same outcome, same goal. And what's going to be important in avoiding the conflict is knowing your own personal triggers and being able to modulate them. So try to determine the source of the problem and how it relates to your patient's medical condition. Discuss how you're going to resolve that issue in their best interest. Avoid defensive and accusatory language, or even a body language that shows you as closed off or dominant, or giving that sense of power struggle. And of course, you can do that by exhibiting that empathic behavior, by voicing that you understand why they may feel that way, or any such expressions. Another thing that's important is being consistent. Consistency among all healthcare professionals that are part of this healthcare team for your patient is very important. And this is very evident amongst pediatric pain patients, where there are multidisciplinary teams involved in their care. All the members of the healthcare team need to and should convey consistent messages regarding diagnostic tests or treatment plans or prognosis or outcomes. And if you don't know that, then direct them to the person who can best give them that information. Next point is making sure that you are able to clarify expectations and set boundaries. It's good to understand and support the patients and families' challenges, their worries, their expectations, but that needs to be done in the context of the expectations and boundaries of your healthcare institution, your clinic, or your professional capabilities. Ensure them that you want to work with them. You want to work together with them as a team to address their healthcare or their pain care needs and concerns. But you also want to ensure a safe and respectful environment for all involved, whether it's the multidisciplinary team, yourself, or the patients and the caregivers. This ends up highlighting a shared goal and expression of concern without that sense of judgment and without that power struggle or the adversarial roles. But be clear on saying what the expectations are from them, as well as what they can expect from you, from the hospital. Even when you have done all things possible, there will come a time when your patient still needs more, either because there's a limit to what your team can provide, or perhaps there's a limit to where you both can see in the same direction. In those cases, it is always okay to get the extended help or additional help, or refer the patient to that help. So that's our next point. Find extended help for the patient. Now, as long as you've earnestly tried to do all that was possible and could be done by you or your team, it's okay to recognize and stop. And you can let them know that care from their own may require additional resources. Whether you incorporate that care within your team and or you refer them entirely to an external team. That would depend on your patient's needs, of course. But this needs to be handled very gracefully and sensitively so that your patient and caregivers don't feel either abandoned or accused or dumped on or hopeless because they have gone through multiple healthcare professionals without getting the help that they need. They need to have some sense of anchoring and some sense of direction. And finally, I would say that if at any point during your interaction, during your visit, you feel threatened, you must get help. Now, even though I said there are no difficult patients, there are difficult situations. There are threatening situations that may arise from differences of opinion. And if you're feeling threatened, being safe is very important. Now, whether you call security or 911 or whatever the arrangement may be in your institution, you need to be able to invoke that. It may be simply that you step outside the room, you may get an additional person. Or if you were already aware of any possible threats, whether it was because of the patient's mental health condition or a history of violence or any other issues that you had an inkling about, then you must always take precautions and perhaps have another team member in the room and or a security person outside the room. Now to summarize this, you are absolutely going to encounter difficult interactions and patient encounters, but this does not mean your patients or caregivers need to be labeled as difficult. Like I said, and I will say it again, there are no difficult patients. There are just difficult situations. Each patient deserves the best care you can give them. Remember that you need to find that grounding within yourself. You need to be objective and empathic. You need to be honest with yourself and with your patient. And that could make a big difference in your patient's attitudes, in your own attitude, and it can absolutely soften those hard edges as well as improve the quality of your interaction, diffuse any tensions that may occur. And how do we do that? We've already talked about those, but remember, first of all, be aware of the root cause of the difficulty of that encounter. Figure it out because you're the professional, you're the expert. And if you can't do it yourself, ask for help. Figure it out whether it's them or is it you or is it the circumstances. Then take an empathic approach. Set limits and boundaries and expectations of your own after you understand theirs. Make sure those are communicated clearly. Keep the goal in mind. Your goal is the common goal, and hopefully you can help the patient see that goal as well. You being able to lead the patient to that common goal will depend on how effectively you use the therapeutic triangle, and I will include that in the show notes. And if you need more help around how to create more engagement from patients' families, I will also include a couple of our podcasts that we've done around communication and narrative medicine and how we can engage our patients more effectively. Next is keeping your patients and your own wellness and safety into mind as well as a priority. And finally, getting help if you need it. Now, folks, that was a comprehensive review of how patients should not, cannot, must not be labeled as difficult. However, how can you address and effectively navigate the difficult encounters or situations? I hope you found this as useful as I have found this framework over the years that I've used it. And as a matter of fact, as a result, a lot of my colleagues refer to me as the difficult patient magnet. And as I said, I don't believe in difficult patients or families. So I hope this will also be helpful to you. Utilize this framework. Plus, I would love to know what works for you. What do you use? What kinds of strategies do you find helpful in dealing with difficult encounters? Share them in the comments. Additionally, share this episode with anyone you think that may be able to benefit from this, as well as provide us a review of the podcast, because that will help get this podcast into more circulation in front of more people that can use it. And we will thank you forever. Now, friends, we're coming up on the holidays, so I wish you all a wonderful holiday season. I will see you with another episode in 1 week's time. Until then, be safe, be proactive. Bye now. Pediatric Pain Focus is a presentation of Proactive Pain Solutions, a company committed to transforming pediatric pain care through improved access, quality, and expertise. Did you know that there are only 4 accredited pediatric pain medicine training programs in the U.S.? Meanwhile, there are 19 million children that suffer from chronic pain. This means the children's pain care is largely left in the hands of untrained healthcare professionals. This large gap in children's pain care leaves both the healthcare professionals as well as patients and families frustrated. Data clearly shows that untreated or poorly treated pain in children leads to a much higher incidence of refractory chronic pain that lasts into adulthood, much higher incidence of mental health diagnoses, and a massive societal burden. It also leads to poor job satisfaction and poor job security for healthcare professionals. Proactive Pain Solutions Physicians Academy is the answer to this major problem, eliminating that large gap through our comprehensive evidence-based virtual training program that's bolstered by live Q&A sessions, personalized mentorship, and leadership development. The limited time enrollment is now open until December 31st of this year, and it offers a limited number of spots. So join our academy today and know what it's like to have the expertise at your fingertips while you enjoy the professional satisfaction and the job security that you deserve. Join us at www.proactivepainsolutions.com.